So we're right on time now. Why don't we get started? My name is Tara Mahoney. I am so happy to be a part of the Education Committee for HHRF. We've really tried to include these webinar series as an effort to make research accessible to everyone, all levels, from people who are already PhDs, people who are just working in the barn and want to learn more, to people who are civilians that are just interested in the healing power and maybe have received services. So welcome to everybody. I am also the CEO and founder of Equine-Assisted Project. I am a trauma counselor with the military. So this webinar series is especially exciting to me. I'm definitely going to geek out on all of the research with Dr. Fisher. So please excuse my fan crush on her, but hopefully y'all are able to have a lot of fun listening. I've actually been following their work for a long time. Two of their treatment team, Jody Jacob McVeigh and Deborah Farber, are actually online also with us tonight. So they've done the whole walkthrough in the very beginning and facilitated the Man of War manual. So we're really lucky to have them. They'll be joining us at the conference, hopefully, with the lead investigator, with Dr. Fisher, presenting on some of the incredible groundbreaking research. So tonight, we are just going to take a deep dive. We're going to let Dr. Fisher do her thing, and I will be happy to jump in and have a conversation with Dr. Fisher as we're going through this. Certainly a lot of people have a lot of excitement, specifically on just the high acceptability and tolerability of this Man of War project. And huge congratulations to the Man of War Project for the new research that was published last Tuesday. It's an awesome read, better than a Netflix binge, so certainly pick it up. Deborah Thompson is actually going to, before we hear it from Dr. Fisher, share the HHRF website. Deborah, thank you so much for doing all the background work for us. She's our whiz on the Education Committee. So she's going to screen share here and let you take a look at the Man of War Project website. One of the incredible things is that the research is available right on their website. So it's pretty unique that you have access to the content of what we're going to cover tonight. So Deborah, if you have any problems with that, I'll just keep on moving forward. Okay, we'll screen share the website. You guys are all capable of going on Man of War website yourselves. So Dr. Fisher, you know, your bio is so impressive. I was going to try to read the whole thing, but I figured it would be a waste of 15 minutes because there's too much to say. So maybe could you just tell us a little bit about yourself and how you got into this work?
Okay. So basically, I'm just going to tell you a little bit about the Man of War project and sort of how we got to where we're going, because Yuval, who's going to your conference, will go more into the neuropsych stuff, but I'll give you some background and sort of how it came about, etc. But before I start, we always have to say this because we're at Columbia, is I don't have any speaker conflicts or anything for this. The Man of War project was funded by a number of different people. It's not a government funded project. It was funded entirely by philanthropy, although New York State Psychiatric Institute, where the Columbia Department of Psychiatry is, and the Veterans Research Center at Columbia did contribute towards it because we're here and we use some of our state time and some of our Columbia time to do it. And I do get royalties from a suicide thing, but it's not really relevant to this presentation. So how did we get here? We are a research department of psychiatry. And although there is clinical work and educational work in our department, but we see ourselves as primarily researchers. And this is a very unusual project for the Department of Psychiatry at Columbia. And the way we got here is that Ambassador Earl Mack, who'd been ambassador to Finland, was our primary funding source, although other people, we've raised some money, we've gotten funding from other places as well. But he was really interested in, well, he was a veteran, But he's very interested in racehorses, and he had been the head of the New York State Racing Association. He had been involved with the Thoroughbred Retirement Foundation and Jockey Club and everything. And he kept hearing about these equine assisted therapy programs. And a lot of them were being applied to veterans and used with veterans. And he was somewhat concerned about veterans because there's a high rate of suicide. And he was quite friendly with the person who used to be the head of the child psychiatry department, David Schaffer, who is was a big suicide expert, and he knew him personally, etc. So he came along to David and said, "Well, what do you think about these equine-assisted therapy programs?" And frankly, David thought they were ridiculous. He thought it was a ridiculous idea, and he was like, "What? That's just like not what we do, right?" And so I worked with David for like years and years and years, and he came and said, "Well, what do you think of this, Prue?" And I'm like, "I don't know." I said that maybe it would be fun. And it's not what I typically do, but it could be pretty interesting. And then, so my expertise is like methodology, assessment. And so then we went up to Walk Hill Prison. And what they have at Walk Hill Prison is the Thoroughbred Retirement Foundation has like herds of retired racehorses. And they do this in a number of different prisons, actually. And the prisoner, the inmates would take care of the horses. So like instead of like going, I don't know, to a different program, they would take care of the horse. There's a weird echo right now, but maybe I'll clear up. And so we went up and visited the program. We saw the horses. We spoke with the guy who managed the program. And they would teach them some horsemanship, but what he kept saying was how people got a real lot out of doing this. And that he would have people who had anger management problems or were very tense. And they just, over the course of taking care of the horses, they would become much more relaxed. And then we spoke to some of them. And actually, it turned out that one of the guys I spoke with was a veteran. And he started talking about how he had real anger management problems, but he can't be that way around a horse. And, so we basically drank the Kool-Aid, and because it seemed like it would be sort of an interesting project to do. Although I will say that people were very surprised that we were getting involved in this. And so when we thought that we would look at veterans, Columbia has a veterans center.
Recording in progress.
That's headed by Marie. And so I said, well, we're going to do veterans. Let's go find Yuval and see what he thinks about it. Because, I wasn't a veteran expert. I'm in child psychiatry. And it turns out that I think the reason David Schaffer asked me about it is because he knew that I'd had a horse when I was a kid. And I liked horses. So then we go and we find Yuval, and it turns out Yuval's had horses. And he really likes them. And frankly, he really has horses again as a result of this project. And so he thought, well, this would be pretty cool because, it's just like, it's a completely new field. And it was sort of interesting. Like, this could be fun. Instead of like sitting in my office, we could go out and look at horse, So we thought this could be fun. Like, we didn't have any preconceived notion it would work. But we thought, well, I mean, how often does somebody come along and ask you, can you look at this? And it seems like something would be fun. And so that's sort of how we became involved in it. And the other reason that Yuval was interested in it, and what I knew in the stuff I'd done PTSD, is that, a lot of veterans have mental health problems. They have an increased suicide rate, which is why Mr. Matt came up, originally. But also PTSD is sort of the signature disorder for veterans. It's often comorbid with a lot of other things. Many people who have PTSD and veterans don't have treatment. Part of it is that they can't get treatment. They're not eligible. They're not deemed eligible. But also a lot of them really avoid or dislike the VA. And there's a lot of stigma around getting treatment. And also the treatments that there are lacking. I mean, a lot of people, even if you get these evidence-based treatments, they aren't getting better. And so there's a lot of room for improvement in treatments for PTSD and frankly, treatments for many mental disorders. So, I mean, it seemed like it would be something that would be interesting and looking at it as an alternative or an adjunctive treatment. And it was something, that obviously we're interested in. We're interested in looking at treatments. So what is it? I think you all know this, that PTSD is a fear-based disorder. Well, that's how we think of it. And basically, as it's defined by DSM-5, you have to experience or witness some sort of traumatic event. So you have to have exposure to something awful. And you have to have symptoms in different areas, and there's a different algorithm for how you put it together. But one is like re-experiencing it. One is avoiding.
Thank you, Pat. Thank you, Pat.
There's a weird echo. One is negative alteration.
Let's make sure everybody has themselves on mute. We're seeing a lot of, movement and hearing some background stuff. So sorry to interrupt you, Dr. Fisher. If everybody could just double check that they are on mute, that'd be really helpful. Thanks. There's a bunch of echoes.
Okay.
Great.
Again, the hyperarousal, the sort of a hypervigilance, and you have to have significant impairment because most DSM disorders, you have to have significant impairment. But in terms of official recognition, it wasn't really recognized as a disorder in the diagnostic system, although until Vietnam. It had been around, and you would hear shell shock, battle fatigue, combat nerve. So there were people who had what we would probably call PTSD in all these wars, right? But it wasn't until after Vietnam that it ended up in the classification system. And that's, so here's some old photos of people with, the 1,000-yard stare. They look like they haven't. So it wasn't until 1973 that Bob Spitzer put it in the DSM-3. And that's when it started becoming recognized. And the thing is that originally it came in because of, with veterans, but now of course it's been expanded to apply to other kinds of traumas, etc. So there's him. So basically, so how does PTSD treated? So generally the best treatment, the best research treatment is some sort of exposure therapy where you end up exposing the person to what they fear, and you do it either by imagining it happening again, talking about it, or putting them in a situation where they feel the same way. And so given that one of the symptoms of PTSD is avoidance, it's a tough treatment for many people, and it's effective for most people in civilian samples who have this single horrible thing that happens. You can do exposure, but for military veterans, it's less effective. But the real problem is that most people drop out of treatment. People that finish the treatment, it's too challenging, it's too upsetting. But there isn't a lot of evidence for a lot of alternative treatments for PTSD through the VA. Now there's some EMDR stuff. But there's a lot of room for alternative treatments. And so from 2014, we say 2015, but it's really 2014 that Mr. Mack first came. Our initial goal was to establish the efficacy and effectiveness of equine-assisted therapy for PTSD. It sounds pretty straightforward. Let's look at how EAT works. And what we found, well, first of all, we didn't know anything about EAT. we don't do EAT. So we spent like a while on our own education we did web searches, we looked at the scientific literature, people would send us books about it. There's a lot of sort of popular press books. We visited some programs, saw what they were doing. We had lots of conversations with people. I went to the Gala conference in 2015 to see what that was about. And frankly, that's when I met Jody. And Deborah, I'm not sure if I met you at that conference or not. Maybe. So the first thing was like our own education. And what we learned was that there are a lot of programs who are doing some sort of equine assisted therapy. Now I think people are calling equine assisted psychotherapy. A lot of the programs that are out there struck us as more like sort of wellness programs, that they didn't seem like mental health programs. Many of them were sort of, or wellness coaching type programs. Many are like at that time were really like one shot type programs. Like Saratoga Warhorse was like, where you go for a weekend, you do something, you come back. Most of them are very experiential, which makes sense given that you're doing things with horses, but they vary really widely in what was done, who did it, what the program was. There were a lot of really positive claims being made, but there wasn't really any standard way of saying, if we're going to investigate does equine assisted therapy work, there's no, what are we investigating? Like, what do we even mean by equine assisted therapy? There's no well-defined way of doing it. And the state of the research was pretty critical. There's a big article that came out in 2014, 15 that everybody's really upset about. And basically said that you shouldn't pay for something that has no evidence base. It wasn't saying that it didn't work. It said that the research was lacking that supported it. A lot of studies are very flawed in that they have very small samples. They didn't follow people up. They didn't have good measures. And again, that there's no set manualized treatment. So when you're asking somebody like the VA or insurance, somebody to pay for it, what are they paying for? Like, what are you telling them they're paying for? Not that it doesn't work. It's just that there wasn't an evidence base to support it. And so our initial tasks were to set up a research team, because that's what we do here. We set up research teams. We got lots of input from faculty and colleagues about what we should do. And scorn to a certain extent, not entirely, but people are like, what are you doing? Make decisions about the treatment and design a study protocol. And we have a team. So as you've all made, and then we invited John Markowitz, who had done a study on IPT for PTSD. And he does treatment manuals. He's a big IPT person. We had methodologists. We had Ari Lowell, who does a lot of treatment, clinical stuff. We had research staff. We had consultants. And then later, the Bergen Equestrian Center and treatment teams, which was a happenstance thing, and that it's 15 minutes from our office. We were looking for a site, and then we ran into a team who were a lot of collaboration with us. So our first decisions right off the bat, and part of this has to do, even before we were educated about it, was no riding. We are not riding instructors. And we're not equine therapists either at that point, but we knew we weren't riding instructors. But we were also very concerned, and part of this has to do with being in New York State. We're very concerned about safety. Having somebody fall off a horse, injuries. Our institutional review board, there's no way they would go for us doing a riding program. But also, as we learned more about it, and our own experiences, that your nature of your relationship with the horse is quite different when you're riding it than when you're standing next to it. And most of the riding programs that we actually saw were for physical benefits, the movement of the horse. A lot of them are physical, and it seemed to us from what we saw, where you would call it like equine assisted therapy or now psychotherapy, they were mostly ground-based type things. So we were gonna go with that. The other thing we thought is it would have to be a group treatment. That would be prohibitively expensive otherwise. Also, veterans are often treated in groups. You can take advantage of a group atmosphere. It's sort of nice not to be directly focused just on the person and this kind of thing. We wanted to have weekly sessions, like instead of a one-shot program, to have like something like most psychotherapy programs, you get like once a week, then you think about it, you're still in your own life, and then so we want it to look like regular psychotherapy programs. Then the question was, well, how many weeks, right? So how long should it be? We wanted to stay within the EGALA model as we had understood it at the time. Okay, we weren't EGALA people. As it turns out, I think the whole treatment team was EGALA certified, but we wanted to stay because the model made sense, and that's basically on the ground. That's solution oriented. This is what it was in 2014, 2015, might have changed a little bit. We like the team approach where you have a licensed mental health professional and equine person. Because we decided, which I should put in the other slide, that we were going to aim it at PTSD and veterans. And PTSD is a serious, problem. And we thought we need to have a licensed mental health professional. We'd like that you have to have a code of ethics. And currently we're doing something with PATH as well. But so that's what we were doing: team approach, on the ground, experiential, ethics. So we thought we fit into it. And then we had designed the study protocol. So one of the things was, what was the length of the treatment? And there's a lot of discussion about that. We came up with 8 weeks. Why 8 weeks? A lot of psychotherapies are 8 to 12, 16 weeks. We were dealing with veterans, and we were worried about recruitment, and we were worried about costs. And so 8 weeks seemed reasonable. We thought a lot about patient safety contingencies, where we're going to be, the equine centers. We did all that. And this is where we were at Bergen Equestrian. Some nice pictures. Then on the protocol itself, originally we thought we would do a randomized controlled trial, because that's what you want to do. To prove something, give something evidence based, that's what you want to have. But there are 2 problems. First of all, what would the appropriate control be? I mean, you can think of a lot of different ways. At one point, we thought about horticulture therapy, which is actually a whole new area that we would have had to do a manual for, which would answer, is it the horse or is it the setting? Is it the bucolic environment or is it the horse? And so, I mean, those are the kinds of conversations we like having, because we think about methodology all the time. But when it came down to it, generally, when people are testing new treatment, we were going to come up with a new manualized treatment. You do an open trial before you do a randomized controlled trial, because you want to make sure you have a signal that justifies spending that amount of money, frankly, right? And a randomized controlled trial is at least twice as expensive as doing an open trial. So our decision was to start with an open trial in the same way most intervention research proceeds. And then we had to manualize the treatment. And why do you do that? Because you want to define, what is your treatment? What are you testing? It will allow for later training of therapists. You can look at testing specific things about the treatment. So what our treatment is, it's experiential within a larger structure. And we wrote a manual with a lot of help. And then the therapist, how to build this. I'll skip that. So who was our treatment team? So we had equine specialists, and Jody was one of the equine specialists. And then we had mental health professionals. We had two different teams. One was typically made up of Deborah and Jody, and the other one of Bonnie and either Sue and later April. And then we had a horse wrangler, and a lot of people, I think the past people called a horse handler. We call it a horse wrangler. I think part of that has to do with geography, because we had gone and seen Alan Hamilton's program, and he called it Wrangler, and I was just in Montana, and I was at a barn, and they were calling themselves Wranglers. So I think it's a Western thing. It's a funny term to us, but we call it a horse wrangler. And then we had a bunch of horses from Bergen Equestrian Center. And now this is preaching to the choir, I know, but we do give an explanation of why horses. Why are horses good for PTSD? And I have now drunk the Kool-Aid. First of all, in fact, it's so funny because everybody says the same stuff, right? If you go to any of these programs, they all explain it the same way. They might use slightly different language because it's a prey animal. And so they're sort of naturally hypervigilant, similar to people with PTSD. They're social, they're herd animal, they're very in the present, in the moment. Sometimes you can say they're very forgiving. They don't hold a grudge, and they're big, right? They're large. They can induce sort of a slight fear response because you're not quite sure. And so, there are a lot of reasons why horses would be particularly good for this. And on the other hand, I wouldn't say every horse is particularly good for this, but horses can be good for this. And so basically, the mental health professional and the equine specialist work together in terms of dealing with the patient and having interactions with the horse. And it's pretty amazing, frankly. So I talked about why you want to manualize it, but as I said, we did make these decisions. We decided we would do 90-minute sessions because often group sessions are a little bit longer, and only to do an hour getting people in and out didn't seem to make sense. I said 8 weeks. They progress from session to session, unlike some of the programs we saw where the horse is completely at liberty all the time. Our program is slow, much slower than that. And we took into account the fact that we're dealing with people with PTSD who might not feel comfortable going into an arena with a horse running around. So it's a very gradual thing. You start out with observing, then you're touching, etc. And every session sort of builds on the session before it. We started out with a draft outline on how it might look. We had gotten some advice from Alan and Jane Hamilton, as well as from the people on the treatment team. And we came up with a draft outline. And then we did sort of mock sessions to see what it would really look like. You can talk all you want, but when you get in and start doing stuff, you see what it really looks like. And they tried out different elements. And it was an iterative process. I mean, we had all these meetings with the consultants and the equine people and the PTSD people, and we found the consultants sort of knew a lot about horses and therapy, not as much about PTSD. The equine team was pretty unhappy with some of the therapy that was being recommended by some of the consultants, some of our consultants are very suspicious of the idea that EAT was chemotherapy. So there was a little tension there at times. And then we just sort of pushed it along. And so there was a lot of back and forth meetings, phone calls, etc. And we came up with something that looked pretty complete, but not complete. We were sort of finishing as we were doing the group. And we tested it out on 2 groups of veterans. And then what we learned from that was some of the things we thought would be good were not good. Like, just didn't look good when you actually did them with real patients and real participants. And so based on the pilot study, we made some changes. In terms of the order, there was this thing we call the trust walk that just really didn't work. And then we did a big open trial. And now we've trained some other people, and we're continuing to train people. So what does it look like? First of all, it all takes place in a round pen. Some programs that you see that are doing EAT, they're in big open fields and big open spaces, but this takes place in a round pen, and it's a group therapy. So if you think of the round pen as like an office or small conference room where you would have a group, as opposed to an auditorium where you have a group where everybody's floating around. So it sort of contains the treatment. 8 90-minute weekly sessions. I told you about the team. The first session is unlike the other sessions in that they aren't really in the round pen for the whole session. They're in it only for the end of it. And that covers a lot of psychoeducation about PTSD, about why equine therapy might work. You give them a sort of a tour or walk around the facility. You have them observe horses. It gives the mental health professional and the equine specialist a way to get an idea of who the people are in the group, right? They also, you have a thing where people introduce themselves to each other, etc. And then at the end of that, you come in and you meet the two horses. They're going to be the two horses, or for the protocol. And then every other session starts in the round pen, where you have an opening circle where you do a check-in and grounding, have some exercises in the middle, and then have a closing circle where you do some processing and talk about what's going to happen the next week. In the final session, you do some sort of graduation thing. So what we do is we give them like a horseshoe to take back with it, and you give them a certificate and pictures of the horse and stuff like that. So this slide sort of lays out what happens session by session. So there's session 1, which is by itself, and then some early phase, middle phase, and final graduation. So here's an example of a session. So this would be session 2. Session 2 is actually the most difficult session they do, because nobody knows what's going on, and you have horses and people, and nobody's really used to it yet. And watching that session, it's the one where it just seems the most chaotic in a way, but then it's fine. But I think Jody and Deborah would probably agree with me on session 2. And that's where you're sort of establishing the framework, how this works, where you're standing, where they're standing. And there's just a lot going on. So what we did is we sort of outlined the tasks to be done. And, it doesn't, although they're sort of like horsemanship type tasks, it doesn't really matter if they do it correctly. It's like how they're doing it. And we so what's the focus of this? Where in the manual, like where might you run into some problems, some discussion about how to talk about, etc. And of course, like if you're lead walking for 15 minutes rather than 10 minutes, it doesn't really matter, but these are sort of suggested times to make it through the session. And then sometimes like there is a grooming thing where you're going to clean the horse's feet and you didn't get to it. It doesn't matter. You can do it in the next session. They're not like written in stone. And then this is a later session, which session 6, you have other things that you're doing. Now, as I was saying about the horses, you can see I'm a little tired because I just taught my first class at Smith, so I keep forgetting where I am. It's not until session 6 in this protocol that a horse is ever at liberty. And that's only for part of the session. It's not for the whole session. But basically, you're sort of building up to it. So I think for the people who are doing it, like the participants, the veterans, And even for me, because I've watched most of the groups, the first couple sessions, it just seems like there's a lot going on. If you've watched 16 groups, which I have, it's like, oh my God, are they ever gonna get to the horses? But it's like, but I'm not the person who's experiencing the treatment, so it's a different experience if you watch them all. But it's sort of outlined and sort of what you can do, and then we tell you what's the equipment you need, this and that, so people are ready to go. So you're in there the whole 90 minutes. And of course, like, it benefits from sort of the common factors that have been shown to help psychotherapy work, which are you have some sort of effective arousal, they feel understood by the therapist, there's a framework you give them for understanding what's going on, they have professional expertise, there's a procedure, there's a lot of optimism, and they have a successful experience. So these are things that a lot of psychotherapy research has pulled out that are like sort of the common factors, and it does include the common factors. And how is it different than other PTSD treatments? First of all, there's no exposure. We do not talk about the trauma. What the participants know is that this is a treatment for people who have PTSD, but we're not going to make you talk about what happened. And indeed, sometimes when we're doing the psychoeducation, explaining what the treatment is, etc., often somebody will say, "We're not going to talk about the trauma, right?" And we said, "No, we're not going to talk about it." So, I mean, you talk about it to the extent that you're determining that they have PTSD and you know what the trauma is, but it is not the focus of the treatment. And because of that, you can have people in the same group who have very different traumas, very different experiences. What they have in common is that they have PTSD, right? And so you don't get into this thing, well, I don't know, that guy's much worse off than I am, or you don't get into a lot of discussion about the trauma. And you just, right? I mean, and I think Deborah can back me up on that. And so what you basically are doing is through engagement with the horses, you're learning stuff about being aware of your emotions, how to regulate yourself, because you can feel nervous and you can see that it dissipates. Problem solving, communicating clearly, self-confidence, self-efficacy. So those are the kinds of things that they're learning that can have an impact on their symptoms. So we had written up this, you can get from our website, the thing about the manual and how we developed it. That was in military medicine. There's Chuck. So then we did an open trial after that because we thought, oh, we correct the manual. And basically what we did is we took veterans who are 18 to 70. These are the inclusion criteria. They had to been in the military service. People say, well, how do you know they were in the military? Well, they told us in the military. We didn't make them bring in papers and prove it. They had to be fluent in English because we don't speak another language. It would probably work in another language. And in fact, the group in Israel is going to do it. But, our treatment team that spoke English, that they had to have a diagnosis of current PTSD at a moderate level. And so they had a clinical evaluation at Psychiatric Institute. They met, we used the skid and the caps and everything. We allowed them to be in ongoing treatment, but they still had to have moderate PTSD. So it was treatment, they weren't better. But if they were in treatment, they had to agree not to change treatment during the courses. They had to be in steady treatment. They couldn't be severely like catatonic from depression or suicide or really suicidal because they needed a higher level of care. So, right. So not that they couldn't have some depression, like moderate depression or some suicide, but they couldn't be where we were concerned that we should switch them to a different thing. They had to be physically able enough. So they had to be able to like walk around, so you're standing up. We did have, I think, 3 people who had canes that they used some of the time. And when people were standing for a long time, they would bring a chair and let them sit down, take a rest. But they had to, for the most part, be mobile. And they couldn't have active out of control substance use because you can't have people who are high around horses. And they could participate in a group treatment. That they were judged to be somebody who could be in a group, right? Like they weren't completely psychotic, they were stable enough, and they had to be cognitively aware. In fact, there was one person who was in the treatment who had traumatic brain injury, who really wanted to do it, and we let him in, and that was actually a mistake because he took too much time of the group. Like he wasn't participating in a group treatment. He was too impaired. But once you're in, you're in. So physical health restrictions, if they're completely psychotic, it's the opposite of the inclusion criteria. Or they're really allergic to horses. There was one person who was somewhat allergic, but he took Claritin or something. So we, of course, because we're a university, or actually a lot of research, any place that gets federal funding, we have an institutional review board that regulates what you're doing. They're very concerned with patient safety, burden, confidentiality. Before you enroll anybody, you have to go through this, and you have to spell out every single part of the study. And if you do something different, it's a protocol violation. It needs to be reported, etc. You keep track of that. They had to approve every piece of recruitment materials. They wanted to make sure that our informed consent was truly informed. They were a bit nervous about equine therapy, frankly. And so they sat in on, we had monitored the informed consent for a while. So we would be explaining the study, and they would sit there and say, well, did you tell them how dangerous it could be? So you had to explain every single problem that anybody could ever have. And it's a new also because it was a new intervention. These are people with a serious illness, et cetera, et cetera. So we had a lot of monitoring. And every time you wanted to make an exception, like there was one person who just met the cutoff for severe depression by 1 point. We had to go to the IRB and said, this guy, but we really think he can do it. And you have to get an exemption from your IRB to do anything like that. So the protocol basically was that obviously you assess people before they go into treatment. Then you assess them at midpoint, which was after week 4. Then you assess them at the end, which is after week 8. And then we assess them again 3 months later to see if they hung on to the benefit. And the assessments were all done by people who were not involved in the treatment. Because, you have the clinician involved in the treatment doing the assessments, well, they want to feel like they're doing better. So we had people who are trained to a certain reliability level, even though it was an open trial and they weren't blind to it. They just didn't have real involvement in whether people got well. And we also paid for the assessment. So you can't pay people to be treated, but you can pay them to come in for an extra assessment. So the assessments were done at our offices, and the treatment took place at Bergen Equestrian Center. And then later on in the study, if people would agree, and if they were eligible for MRI, we had MRIs before and after, and they got additional compensation because that was yet another visit to a different center to get an MRI. Now, some people weren't eligible for the MRI because they had a lot of tattoos or they had metal in their body. Whereas you can have an MRI if you're like, if it's for a medical problem for your benefit. Like you can have a tattoo and have an MRI, and then you'll be carefully monitored because a lot of tattoos have lead and metal in them. But not for a research study. It has no benefit to the person. So like some of our veterans couldn't have MRIs because they had tattoos, significant homemade tattoos, so stuff like that. And one of them, the machine was not the size of the MRI couldn't accommodate this person. We provided transportation if they needed it, which is something to think about, especially with veterans. And also, as part of being in a research study, I mean, a research study, it's funny because you really, it's interesting because later we were training people from PATH, and we realized like we have very few people drop out or anything because we really, in terms of doing an informed consent, we are very clear about what it meant to be in the study. That is, this is an 8-week protocol. You really need to come every week. How are you going to get here? So it was like a really practical approach, because in a research study, you don't want to get somebody in who doesn't really want to do it, right? Because they're going to, so you're really clear from the very beginning. And I think that, I mean, nobody dropped out. I mean, people do drop out of research studies. But, we were very careful about explaining what they should expect. Part of that is because of the IRB we had to do that. But also, I think just in terms of when you use this kind of protocol or this kind of approach to treatment generally, you should be really clear. Like, you don't want somebody to start any kind of group if they are not clear that they want to do a group, right? Because you have a group dynamic going on. So you should clearly explain what the expectations are before you enroll people in any kind of structured protocol. The MRI component was done to better explain the therapeutic benefit without, in a way, because an MRI is done by a machine, it can be seen as more objective. So we introduced that. So we were looking at both structural and functional. And Yuval's going to go into this a lot when he does his thing at your conference. So the MRI thing was pretty interesting, but I'm going to let him do that part. But there's our MRI machine. So basically, what happened in the open trial? So we got 60. First of all, we screened 186 people who called up and saying that they've been, they might have PTSD and they're interested in this study. Of those, a lot of them didn't meet just the inclusion criteria right off the bat. Either on a screen, they didn't really have PTSD, or they were suicidal, or they were whatever. So a lot of people got excluded. And then we had 97 people actually come in and go through a full screening, a full clinical interview to see if they were eligible. And of those, 34 of them weren't eligible once they had seen a clinician. And so the people who actually entered the study, there were 63 people. And only 5 of them didn't finish the protocol, which is sort of unheard of, frankly. And then some of them didn't get followed 3 months later, because we can find them 3 months later. But only 5 people didn't finish the protocol, which is pretty amazing, frankly. And so this is a paper that just came out. So we had a low rate of dropouts. And frankly, one of the dropouts never even started the protocol. I mean, and when you're doing a research study, once somebody has signed a consent form, even if they never get the treatment, they're considered a case, right? And so really, it wasn't 5 people dropped out, 4. I mean, he didn't get even, he smashed his hand in his car or something. I mean, something happened, so he couldn't participate. And so basically, the good news was that people really liked the treatment. And we didn't have any study-related injuries. Nobody got worse. We had, I think, 37%, nearly 40% women. We had 16 different groups. So the groups ran from 3 to 4 people in a group, usually 4. I think maybe one group had 5. And only one of the groups was a pure male group. The rest of them had males and females in them. They had very mixed traumas. The other thing I should tell you about the trauma, we did not require that it had to be a battleground trauma. You know, they could be their trauma that got them to get PTSD it could have been childhood trauma. It could have been something that happened after they were out of the military. We saw a lot of military sexual abuse, both men and women. And what we found that there's a significant decrease in PTSD and depression symptoms for most of the people by the end. So this is all these different ways of using it. One's called an intent to treat model. One's called everybody who made it to the end. And you said there are different ways, but they all show the same thing. That basically the CAPS and the PCL are the PTSD measures, the HAM-D and the BDI are the depression measures. And this is all in the article if you want to look at it in detail. But, you know, basically everybody, you know, the groups improved. And so basically it's potentially safe, well tolerated, a large effect size and standard ratings. The treatment benefits were across all the outcome measures. They largely persisted for 3 months. 51 and 54% of veterans demonstrated clinically significant change at post-treatment and follow-up. So 51% at post-treatment and 54%, and clinically significant was predefined, but most of them improved somewhat. 46% below the cutoff score at post-treatment, right? And so we were happy. We were pretty happy. We were surprised. We were looking for a signal. We think we found a signal. We think it would warrant doing a randomized controlled trial. And basically, I don't think the randomized controlled trial actually has to be in veterans with PTSD. I think it could just be in people with PTSD. And so, because the thing is, you really sort of want to have, when you're doing these kinds of trials, you really want to have people who are symptomatic enough that you can see change. Like if people are just sort of you know, you can't see the change as well. So we want people to be moderately happy PTSD, at least a moderate level, to do a randomized controlled trial, but we don't think you would have to confine it to veterans. Now, the thing about recruitment, and you know, we were lucky because we have funding to do it. Recruitment was, you know, once you get people and you recruited them, it was fine. Like nobody drops out. Recruiting was a whole thing by itself. I mean, it's so funny because you say, oh, you know, equine therapy for veterans. Aren't there a lot of veterans with PTSD? Wouldn't this be great? Yeah, we all think it's great until you start getting them for a study. It's a hard to reach population. People with PTSD are a hard to reach population, especially veterans with PTSD. We had open houses. We had 4 open houses for providers, referral sources, and community. And actually, I'll tell you something funny. One of the open houses, you know, our RRB was so worried about being safe. The only thing that ever happened to anybody where they were at least hurt at all was at an open house for a provider where she stuck her hand in the horse's mouth and it bit her. Nothing like that ever happened in the treatment thing. We had stakeholder meetings. We had meetings at VAs, vet center organizations, disabled veterans groups. We sent out flyers all the time. We hung them up all over New York City. We went to vet events. We got in touch with unions and firefighters and transit workers, you know, things where veterans might get employed. We did a lot of presentations. We had a lot of media because Ambassador Mack was into having media. We had a website, we had Facebook, but still it took quite a while to recruit. And also because we were doing a group intervention, right? So not only had to recruit, we had to recruit people who could commit to be someplace 8 weeks, the same time of the week, you know, etc. And we didn't have a connection with the VA. Like we're our own vet center. like to do this going forward, you would want to do much more. It'd be easier to do it if you were actually at a VA. And veterans with PTSD as a group have really complicated lives. Lots of medical issues, lots of appointments. Many have legal cases going on, issues with, their families. They're much more likely to have housing issues. We have a couple of veterans who are homeless. They can have work-related issues, like if I need to go to a doctor's appointment, I can just go to a doctor's appointment. Sometimes they can't go to a point. They can't change their schedule. They can have difficulty traveling. Our offices are in New York City, near the GW Bridge. You have to take a subway to get to our office. If you have PTSD, often you don't like being in crowded places like the subways. And so we have this one person who would ride his bike. We do have a bike rack. And I think our group was Tuesday mornings. And on Monday nights, I was like looking at the weather to wonder if he could get to our office. Because once he was here, we could give him transportation. So some people, one group we had was at night. In the evening, we had a morning group and an evening group. And some veterans didn't want to go to the evening group because they didn't like to be out after dark. So could be a difficulty with that. And then for the MRI, often they have metal in their body. We had an advantage in that because we are at Psychiatric Institute with a connection to the Military Family Wellness Center, we could offer free treatment services. So at the end, like sometimes people would have the EAT PTSD and they want to go on and get other treatment. We could offer free treatment to them. Our veteran center supported a full-time outreach person. And we were lucky because we had expert assessment and supervision through the Veteran Center. One of the things that people liked about this was when you're doing a research study with the university faculty, we could assure confidentiality. People are very suspicious of the VA and if things are going to be confidential. And, a research study at a university is all about confidentiality. So we had those advantages, but still it was difficult. So what is it? It's a group treatment. You don't address traumatic experiences. And of course, there's a growing body of literature, some by John Markowitz, who demonstrated that doing exercises where you have to keep reciting your traumatic experiences is not always a critical component of recovery. It's specified, it's manualized, you define roles for what they're doing, so it's structured, but it's still experiential. The sessions are progressive, and the structure and activities were chosen keeping that people have PTSD in mind. And how does it differ from other equine programs or protocols? First of all, with the manual. Although there is flexibility, but there is some fidelity that you have to do, that we use comprehensive assessments to track progress. Even, in day-to-day stuff, doing equine therapy, perhaps you don't have to be as comprehensive as we were, but I do think it's important to track progress to see what you're doing. Also, I also think it's important because what happens with equine-assisted psychotherapy or therapy is that people will think they're getting psychotherapy, right? And so because I'm getting this, I'm not getting something else. So if they aren't getting something that or there's some indication it might work, then they shouldn't, maybe they should get something else. Like, I just remember from my dissertation, totally different topic, but it had to do with parents whose children had died by suicide. And a lot of them, we were doing family center, we were doing all these assessments, and a lot of them had significant mental illness, not surprisingly, and they weren't going for treatment because they were going to bereavement group that was not necessarily led by any kind of professional, and they didn't look well. I mean, I was seeing them a couple of years after their child died. They should have been referred, I think, by the person leading the group to some other kind of help. So I think often, even with these alternative treatments, I think it's important if you're treating somebody who has a significant psychiatric or mental health problem to have a licensed mental health professional who can monitor that and know what to do if the person's getting worse or it's going on. So I just think it's really important to have this team approach and track how people are doing. The observations that I was really pleased about, the thing I was the most pleased about was that we had two different treatment teams and they look really different. Like they didn't watch each other, but I watched them both and they operate very differently. Like one, the mental health person is a lot more talkative and the equine person is less talkative, and the reverse for the other one. And stylistically, they were just different, but they both had similar results. So even though you've spelt out this sort of protocol and this way to do it, there is some flexibility in how you implement. I mean, people aren't widgets. So there is some, you still have to have rules about how to run a group and all this other stuff, but it was that to me was a really big relief. Like a really big relief. I don't know if the teams know how big a relief it was to me, but it was. So our next steps are what we're thinking about doing is establishing a man of war center at Columbia, at CUIMC. And basically we came up with 3 sort of goals about what we wanted to do. And one is just to continue to carry it for the research. Like we'd like to do an RCT. And that's really important if this is really going to be considered evidence-based. It's just important to do that. Perhaps with partnerships with the VAs or partnerships with other people that we would train who have access to veterans and agree to participate in our study. And participating in our study means using our protocol and the way we say to do it, allowing people to be randomized. We would come up with an appropriate control. It might even be a time control. Being trained by us, being certified by us that they are doing our protocol. And perhaps in that kind of scenario, we might even do the assessments now that everybody's getting so used to Zoom and stuff. Like we could probably do the assessments, but we would want to have clinical backup. Another thing that we've been asked to do a lot is to train others in the protocol. Our first foray into training was training some PATH centers. We learned a lot from that. And we made a lot of additions to the manual, things that didn't happen. And so PATH is coming out with some sort of course that people can take. But I liken that to if you wanted to learn how to do motivational interviewing, there's a lot of stuff you can do on the internet, but it doesn't mean that you're officially trained and you're doing motivational interviewing. So I think that even with this, I think there is a need to have people be supervised in the same way. You can read a book on CBT, or you could go really take a course and learn it really well. And you know what I mean? So we're going to start training others more intensively. We have been training a group in Israel online. But with Zoom, it's not online, they're live. Dissemination of the manual. Looking at more about how to get horses prepared for it. We were lucky, but that's not an area we knew that much about. We were just very lucky working with Bergen County, but there is a lot of interest in giving horses careers and how do you select a horse. We're aware that not every horse is good for this. I mean, the horse I had as a child would never. I mean, he was scary. I mean, there's no way this horse would have done that. So, and just preparing the horses from when you do it, like practicing with them. You don't want horses who kick people, all this. So there is some preparation stuff. And then the thing that we're starting now is looking at adapting this protocol for a different population. We're going to be piloting it, an adaptation of it for anxious youth, because and I don't think it's going to take that much adaptation, but a lot of the things that we noticed in terms of emotional regulation, communication, feelings of competency, feelings of self-esteem and agency would be and doing it in a group setting would be something that seems completely applicable to that population. And so we're looking into that. I think there's one other thing I wanted to say, but I don't remember what it was. But I mean, I was pleasantly surprised, like really shocked that it did work out so well. I mean, I think that, this is what I was going to say. The one thing that really struck me, I don't know why I didn't put it on the slide, is, when you're working in a mental health setting, or just anything where there's a treatment going on, and you see people sitting around the waiting room, and they're waiting to go to their group therapy or their group anger management. Like, nobody looks happy to be there, right? Nobody is there. That is not the case in this. People would look forward to the sessions. I mean, they would come in and say, I was thinking about this all week. Like, I'm always looking forward to Monday. I have never seen somebody do that in a group. Like, it was pretty interesting. So, that's where we are. So I'll stop here.
Oh my gosh, so great hearing from you, Dr. Fisher. I think one of the most groundbreaking parts of what you guys have done is you have manualized it, you've documented it, and you've published it. And you're right that so many anecdotal stories, so many different team models, so many different things, but to be able to have the protocols that you have and that you're sharing and that you've spent so much time focusing on, but really measuring, the fact that, their CAP scores decrease so significantly. That's huge. That's hard to do in any type of therapy. The fact that it's so tolerant and acceptable with such a low dropout. 30 to 40% of veterans typically drop out of traditional therapies. The social and emotional piece, the emotional regulation, the self-confidence, all of those things that are those intangibles that can be really hard to measure. And we've all talked about in the industry for years. To have you buy in and really start to put some, some facts behind it and some research behind it. We're just really grateful in the industry.
I mean, one of the things that I noticed myself, and I think Jody and Deborah can speak to this as well, is people look different at the end.
Yeah.
They just look different. They were standing up straighter. They felt confident. And we had this guy say to us, when we started out, the horses look so big, but these aren't very big horses, are they? I mean, it was just really strange. And sometimes, like in the opening circle or the closing circle, we were videotaping everything. I was like watching everything. They would say stuff like, you're thinking, did somebody tell him to say that? I mean, it was like being in a movie or something. It was really strange. Like, I wouldn't have believed it.
No one ever took selfies of themselves on the couch with me, in my office, but boy, they'd come and take pictures with those horses. And Jody and I had done some work together, and Jody, you can say to that. I mean, we would take people out and just, you're right, just after 20 minutes, all of a sudden that person's breathing slower. And I think all of us see that. Jody, do you have anything to add to that? You or Deborah to kind of jump in here? Nope, you guys on the spot. Just put you guys on the spot. Don't worry about it. But you're absolutely right. I mean, if anybody has questions here, certainly Yuval will take a deep dive into the research and the really what it means that the functional and structural changes mean. What is actually, the caudate pruning and all of those really interesting, parts that came from the fMRI. I mean, that is really huge in the industry. But, again, what Man of War really showed us was that it's acceptable, it's tolerable, it's, really embraced, and the community can buy in.
And one thing that was very funny when we were first looking at these programs, and Yuval and I went around to a few programs, we would come back and we would be in such a good mood. Right? We just would. And I remember I was driving home with my husband, and I was saying, Dave, I think this really could work. Because we would just be like this. He goes, Prudence, you don't have PTSD.
Yeah.
He goes, yeah. He goes, it would be bad if you didn't feel good, if you felt awful after going, but so what? You feel good, but so we were happy.
I had a veteran ask me the other day if he could do a study on measuring why we all like the smell of a barn. We joke and say it's aromatherapy, but he was like, that would be a great research study. I just walk in, I'm like, so you're right. You're right. There are so many pieces to this.
But also at the end,
we talked about, yeah.
At the end, the people, because I did exit interviews with a lot of people.
Right.
They wish it could go on, right? And so I said, well, we asked, was it too long, too short? So they'll say, oh, it's too short. They wanted to go on. And so I would say to them, well, if we had told you at the beginning that it was going to be a 10-week program, a 12-week program, would you do it? And they said, no. And I said, well, we do have something called informative, so we can't just change it. I mean, so basically, yeah, I mean, people liked it, and they did look forward to it.
But that's really relevant too, and that might be next steps also. Is what does graduating from Man of War 0.1 and then Manage for 0.2, or what is that continuity of care and how is that offered? So that could be really something interesting, that probably a lot of us who run programs or work with clients on the ground might see that. Yeah, why does this get people to come? What do you think?
I think there is this. I think there is something about being around them. I do. I think it's this. I think it's everything.
Yeah.
I just wanted to say, since you invited us to say something,
yeah.
So I did just want to say that it was really interesting as a practitioner to be involved in a research study, because although I see changes and have seen changes before, it was so rewarding to get the evidence that we got and the feedback that we got that absolutely correlated to what Prudence was saying about even their physical appearance and everything. But then you also had the data to, that supported it too, because I think those of us that are doing this work, we've seen things that have changed. We've seen people move forward. We've witnessed it and witnessed that, but it was just so rewarding to also see the evidence, in the black and white, and then just visually seeing the confirmation that the black and white information was lining up. It was very rewarding.
Yeah. And one of the things I would say is I wish that we had added some additional measures, and done this more systematically. I mean, in the next study, I would do that.
And I just wanted to say that Yuval is going to be talking about the neuroimaging study, and Deborah and I are also going to be in North Carolina, and we're going to dig into how we manage the process and work with the groups. Deborah, you want to add something?
Right, because the thing that was really interesting too is, the team approach, and it was interesting when Prudence was talking about the second session that seemed, chaotic and a lot going on that we certainly concur with too in our experience. But there's so many aspects that there's sort of like a relearning for the mental health professional and also for the equine person, in the sense of, if you're used to, if your role is usually, horsemanship and training people with horses, we both of our roles, we have to sort of relearn, how to do that in a way that facilitates the client coming to their own conclusions. So it's interesting because we've had opportunities, as Prudence said, to train some other people in the protocol, and we had been swimming in it for years. So then now you're going to teach it, and the nuances that we kind of had been swimming in for years were things that we didn't realize really needed to be stated, because they were things that we had gotten into a rhythm of how to do. So I think what we've been able to do now, and what we hope to do at the conference too, for anyone that's looking to do the protocol, is to give a little insight into what those nuances are in your team relationship, and how the whole thing, even though it's a structure, as Prudence said, experiential within a structure, we are moving with the clients as they're moving too, and where they are. So it's definitely client driven, even though we are doing it in a structure. And that's like a really interesting dance to be in, and to be in a team approach, as opposed to a therapist who's in your office, working on your own. So that's what we hope to give some insight into. And some other things, I'm sure, Jody, that you might want to add, if anybody's interested in, what might be available at the conference.
Yeah, well, I mean, we can also, it sounds like that there is an interest in, how we selected horses and sort of our thoughts on it. I definitely have my own thoughts on it. So we can, maybe we could dig into that in North Carolina too. Might be kind of fun.
Yeah, one of the things that our team is always sensitive to is the burnout, compassion fatigue, the resilience of the team. What if someone moves away, and now you've had that amazing bond, with my team, I can just give a look, or they can give me a look, and we know what we're saying. But how then what you guys have created is such an interesting thing, is that it's standardized. So really, of course, that co-facilitation and that treatment team rapport is so important, but because you said it's replicable and it's standardized, that's really hopeful, because, there's only one of me or one of my ESs. Well, now there's 10 of us or 20 of us, and we're all doing the same thing with the same results. But yeah, the compassion fatigue, our team talks about a lot, as, what about the horses and suitability? So certainly would love to hear more. And maybe that's the next webinar other than the conference. But we've gone over time, and really want to respect everybody's time. Thank you all so much for actually staying the extra minutes. I mean, just fascinating, and more to come. Of course, the recording's available on HHRF's YouTube channel. Please check out the Man of War website. The documents are there. It's a great read. I promise it's not a bedtime read. It's definitely an early morning cup of coffee, maybe 2 cups of coffee read, but it is fabulous. Really exciting stuff. And we're just so grateful for the work that you've done. Thank you all so much.
Thank you.
Thank you.
Have fun at your conference. I wish I could be there.
Enjoy your wedding. Enjoy the wedding.
Yes. Yeah, it's going to be a great time.
Thank you.
Thank you.
Bye.
Bye.
Thanks so much, everybody. Have a good night.